Thank you, Sonali. Thank you to this invitation for Eva and Bertrand. And thank you also for this very simple question. As you know, the recognition of CHOP as a standard treatment probably dates from the early 19th, when this trial showed that CHOP had the same efficacy as different regimens, which had more important toxicity. However, these results were not satisfactory, and many investigators attempted to improve the regimen. Some of them were quite successful, using dose-dense regimen with a shorter interval between cycles, dose-intense regimen with higher doses, or with high-dose consolidation and autologous stem cell transplant, which raised many discussions. But of course, the most significant improvement was the association of rituximab to CHOP. This improvement was shown in every age class and every risk category. So, were the old recipes still successful at the rituximab era? Certainly not for those dense regimens, the difference being erased by rituximab, CHOP 21 and CHOP 14, giving the same outcome in young and older patients in two large phase 3 studies. Probably yes, for intense CVBP in young patients, but at the cost of an increased hematological toxicity. Maybe for high-dose therapy consolidation and autologous stem cell transplant, but different regimens showed quite heterogeneous results. Two of these studies in high-risk patients have shown a reduction of the risk of progression in patients who receive an autologous stem cell transplant, but no benefit in overall survival. This practice could not be generalized as a standard of care. Consolidation of CHOP by radiotherapy is a debate to the issue. Recent results indicate that irradiation did not improve disease control in non-bulky disease, but a retrospective study and unpublished result from the German Unfolder trial, which is still ongoing, showed that radiotherapy could reduce the risk of progression in patients with a bulky disease treated with CHOP. The role of PET scan in these patients is still under evaluation. Most important elements guiding the standard treatment are simple clinical factors, age and other risk factors of the IPI. These elements are gathered in the European ESMO guideline with adaptation of the number of CHOP cycles according to the number of risk factors. Patients with higher risk being proposed more intensive treatment, and older patients less intensive chemotherapy. However, with respect to these guidelines, almost 30% of the patients had a progression at 3 years, and 20 of them died. Effort to improve this result beyond standard CHOP could be followed in two directions: the early evaluation of disease sensitivity and the development of new tools which take advantage of disease biological property, as said by Sonali yesterday. Interim PET, after 2 or 3 cycles of CHOP, is a powerful tool to predict treatment outcome. This has been confirmed in many studies. It appeared that this approach could help to change the treatment of patients, as those with positive interim PET who had less chemotherapy sensitive disease. However, two recent studies have shown the limits of this approach. The PETAL trial, where positive interim PET remained highly predictive, but where change for a more intensive treatment at this point was unable to improve the outcome of patient treated with R-CHOP. And the trial for the British Columbia, where PET-positive patients were proposed an alternating treatment with rice. In this trial, only very few patients could convert from PET-positive to PET-negative after this switch. Indeed, looking at results of interim PET in diffuse large B-cell lymphoma, the more constant and homogeneous feature is a favorable outcome of patients with a negative PET, as compared with a very heterogeneous outcome of PET-positive patients. This leads some groups to use the interim PET as at minimizing treatment-related toxicity while maintaining treatment efficacy. In our group, two trials are ongoing. One in low-risk patients, where PET-negative patients only receive 4 cycles of R-CHOP as compared with the standard 6 cycles. And the other one in high-risk young patients, where interim PET-negative patients do not receive consolidation, radiotherapy, and autologous stem cell transplant, which is our standard in this population for us. DNA sequencing-based monitoring could also be a new tool which could replace some imaging methods. Clonal DNA is constantly detected in peripheral blood in patients with diffuse large B-cell lymphoma. Persistence of or early recurrence under treatment is correlated with a poor outcome. Molecular relapse during surveillance could predict a clinical relapse. New treatments will have to take in consideration the biological diversity of diffuse large B-cell lymphoma. Of course, I won't talk about MYC and double-hit lymphoma, but focus on differential efficacy of treatment in molecular subtypes of diffuse large B-cell lymphoma. As shown by Sonali, large-scale expression profile showed that diffuse large B-cell lymphoma could be divided into 3 subtypes according to a different cell of origin: germinal center B-cell, activated B-cell-like, and primary mediastinal B-cell lymphoma. Retrospective studies of patients treated with CHOP and then R-CHOP showed that GCB subtypes had a better outcome than EBC subtypes. The genes associated with GCB include markers of germinal center differentiation, while the genes associated with ABC subtype regular plasma cell differentiation. As determination of gene expression profile is not easily used in a clinical routine, immunohistochemistry methods have been developed and spread in order to approach the determination of cell of origin. Newer methods based on the evaluation of a limited set of genes and which can be used from paraffin sections have been validated in comparison with standard gene expression and are now used in clinical trials. It appeared that differential efficacy could be seen in different chemotherapy regimen. The dose-adjusted epoch associated with rituximab appeared to provide a very good outcome in GCB subtypes. Maybe it's there, double it, lymphoma there. On the contrary, the survival benefit or ICVBP over R-CHOP seems to be at least partly linked to improved survival among patients with non-GCB diffuse large B-cell lymphoma. IBC, diffuse large B-cell lymphoma, is characterized by constitutive activation of NF-kappa B pathway with different mechanisms. It is associated with proliferation and tumor resistance. Bortezomib blocks the degradation of NF-kappa B inhibitor protein. An early study suggested an elective effect of bortezomib on relapsing ABC diffuse large B-cell lymphoma. A more recent trial showed that the outcome of ABC diffuse large B-cell lymphoma patient treated with a combination of bortezomib and R-CHOP was the same of those with GCB subtypes. On this assumption, several randomized trials are ongoing to compare R-CHOP and bortezomib R-CHOP, including a nearly completed large phase 3 trial in the UK using gene expression profile. Lenalidomide may also have selective activity in ABC subtype by inhibiting NF-kappa B pathway, but its mechanism is much more complex. Single-agent study confirmed this effect in clinical setting, and now the combination of lenalidomide with R-CHOP, this is R-square-CHOP, has been suggested to overcome the negative impact of the non-GCB subtype. Here also, randomized studies are ongoing to compare the R-square-CHOP combination to standard R-CHOP or to use it as a maintenance treatment as in the REMARK trial. B-cell receptor signaling is chronically active in ABC diffuse large B-cell lymphoma. The BTK inhibitor ibrutinib has been shown to block BCR signaling and to kill ABC cell lines. A single-agent study conducted by the NCI has confirmed its clinical activity and shown different mutation profiles which could be correlated with this activity. Early combination with R-CHOP showed an acceptable tolerance and interesting efficacy, which encourage now launching a phase 3 trial, the Phoenix trial, comparing R-CHOP and ibrutinib plus R-CHOP in non-GCB diffuse large B-cell lymphoma. Numerous molecules are in different stages in clinical development that could target oncogenetic mechanism involved in different subsets of diffuse large B-cell lymphoma. But another important way to improve the first-line treatment is to modify the immunologic part with a better pharmacokinetics of rituximab, like in the German experience, or with new anti-CD20 antibodies, or also with antibodies targeting different antigens, in particular antibody-drug conjugates. In this domain too, phase 3 trials are ongoing, which compare the combination of a new combination with R-CHOP, as in the Guaya trial and GAIN trial, which use obinutuzumab antibody. So in conclusion, if today R-CHOP remains a standard treatment, it is clearly unsatisfactory for high-risk patients. There is no doubt that combination with new targeted molecules will change the future of treatment of diffuse large B-cell lymphoma. Until this time, R-CHOP, with a favorable balance between efficacy and toxicity, will remain a potent platform to assess these combinations. Thank you for your attention.